Ladies and gentlemen, we now move to a keynote that zooms out to look at the larger ecosystem of equity and accessibility in IVF care across India. As we've seen today, access to fertility care is still deeply uneven. Geography, income, awareness, and social stigma continue to dictate who gets to become a parent with help and who does not. Our next speaker, Dr. Madhur Hamine, brings a strong lens of clinical experience, patient equity, and system design to this conversation. Dr. Madhur is the co-founder and director of Oospheere ART, a pioneering IVF lab network that is raising the bar for clinical embryology and ART lab excellence across India. With a strong academic background in clinical embryology and a commitment to global standards, Dr. Madhur brings over a decade of experience in embryology, fertility diagnostics, and ART lab design. He has worked with some of the country's top IVF clinicians and centers, helping optimize lab outcomes and patient success rates through evidence-based technology forward practices. Please join me in welcoming Dr. Madhur on stage as he delivers his keynote on Bridging the Gap, Equity and Accessibility in India's IVF Landscape. Can we please have a huge round of applause as he joins us on stage? Over to you, sir. Requesting everybody to please remain seated as after this session we will be breaking for lunch. Thank you. Over to you, sir.
Thank you. Yeah. So first of all, I would like to thank everyone, and especially the IW Council, Mr. Kamal, and ESR members and IFS members. I think, am I audible? Yeah. So can you please increase this sound because I will be little moving. मुझे लगता है कि बहुत सारे लोग लंच के टेबल के पास में है and they must be very hungry. So I will keep my presentation very crisp and very small because most of the points about accessibility and equity is covered in previous two sessions. What I will do is I will just present you the structured discussion what you had heard in two previous sessions. So let us move on to, this is not moving. और थोड़ा देर भूख सहन करना पड़ेगा. Yeah. Yeah, so I would start with the disclaimer. I will start with the disclaimer that I am not an IVF specialist, neither I am a lawyer or a policy maker, and I don't represent a corporate IVF chain. And also, I am not a IVF equipment seller. Now, having said that, what we have learned is basically from working at a grassroots level, from Tier 4, Tier 3 cities to the metros, Tier 3 towns, Tier 4 towns which are less traveled, interaction with 600 plus gynecologists, we have gathered the insights, and a real world conversation between them. So through this, what, again, I think it is stuck. Can I have stuck? Yeah. So what we are doing is, fortunately, I have my co-director, Dr. Dilip Walke, who is an eminent name in Foxy Circle for his medical, legal and ethics work across country. So he is my co-director. I have more than 25 years of experience in the healthcare management field, and along with us, we have Advocate Amit Karkhanis, who is a medico-legal expert. Now, what we have put together is a collective domain wisdom of 50 years, more than 75 plus IVF centers, mostly concentrating in Tier 3, Tier 4 cities of India. And we provide a 360-degree IVF turnkey solution, starting from feasibility, whether you should start the IVF center or not, to running the IVF center. So we have onboarded around 60 ART consultants and embryologists with us who are specialized. They are top-notch people, and that is how we have developed a trusted partnerships with the gynecologists, with the investors, to reach out to the people which is where it is needed the most. So that is where we are making the difference. Next, please. So let us talk about the accessibility and equity in IVF especially. So accessibility means access to the IVF center irrespective of the physical condition, the financial problems, the social and cultural stigma it has. Irrespective of that, the intending couple should have the access. And equity is a fair opportunity for all, irrespective of a geography or income. I'll tell you one small story about recently happened in 2022. In a small village in Odisha, a 12-year-old girl died because of a common crate snake poisoning bite. Now that girl died in a very remote place wherein the equity or the accessibility to the better facility is not available. And just compare it with the 80% of the population which is residing in Tier 3, Tier 4 cities, especially when it comes to the IVF facilities. Next slide, please. Next. So we have been discussing about the IVF revolution in India and the growth it has seen. Now you can certainly see from the birth of Kanupriya in 78 to the present, it has grown tremendously. The ART registry shows around 2,500 clinics registered, and approximately 6,500 clinics have applied, out of which only 2,500 has been registered. And we have seen also a huge growth in terms of corporate chains, AI genetic screening and all. Whenever we attend the conferences, especially when it comes to the ART practices, what happens is we talk very high-end gadgets or the evaluation methods or the treatment methods. And then with all that, we are currently doing around 300 cycles, which is expected to grow almost double till 2027. Next, please. Now, what this slide will show you is a inequality when it comes to the larger population. So this slide shows that around 55% of the IVF cycles are happening in Tier 1 and metro cities, Tier 3 cities and rural around 33, and only 12% where 70% of the population is staying. Only 12% of the cycles are happening in Tier 4 and rural cities where the need is most. Next slide, please. So we will address the entire scenario in 4 sectors. Let us understand the problem statement. Most of the slides you might have heard the discussion upon, so I will skip it very quickly. Next slide. So this is a gross dichotomy which has presented to us. These are, I usually call these as a IVF deserts. So these are Northeast India, Eastern India, Central India, Western tribal belts, and probably South Indian coastal area, which has got a very less concentration of IVF center. Now, when you say most of the IVF centers, almost 70% of the registered or unregistered IVF centers yet to be registered IVF centers, are situated in 8 metro cities of India. Now, this census, what we have seen, or current papers are there, are basically based upon census of 2011 and the white paper published by EY in 2015. Now, the numbers may be little more, but the dichotomy is huge. So almost 60 to 75% of the population which is eligible for infertility treatment is not rich. And that is where exactly we focus upon. So we are basically a business catalyst. What we do, I'll explain you. Next slide, please. These are the barriers in accessibility. I think most of the panelists have discussed about geographical limitations and high treatment cost and social stigma and lack of awareness. So let us fine tune, let us see one by one. As you see in this graph, awareness about versus the affordability, tier wise if you see, as you move from tier 1 and metro cities towards tier 4 cities, where the most of the population stay in tier 3, tier 4 city or tier 2 city partially, the awareness and affordability is slowly decreasing. इसलिए मेट्रो सिटीज में ज़्यादा कॉन्सेंट्रेशन है IVF सेंटर एंड IVF फैसिलिटी का. दे हैव गॉट मोर इक्विप्ड treatment modalities than tier 3, tier 4 cities. And that is where, and I have defined the kind of the tier system which I am talking about. So less than 1 million tier 4 cities are 5,000 cities in India approximately. So we are talking about a huge population which remains underserved. Next slide please. फाइनेंशियल इनएक्सेसिबिलिटी, ये तो सबको मालूम है कि IVF के कॉस्ट ज़्यादा है एंड वेयर द रिजल्ट्स आर नॉट वेरी अश्योर्ड. आई मीन नोबडी कैन से कि भाई मैं 100% रिजल्ट देता हूँ. सो दैट इज़ वेयर वी नीड टू बी एड्रेसिंग द इशू. हैविंग सेड दिस, द treatment is not limited to one cycle only. You may require repeated cycles. You may require frozen embryo transfers. There are patients who require repeated stimulated cycles. So we need to understand all these things. And next slide, please. I would tell you the cost versus income. Now, the NNI per person per capita is 2.05 per year. Now, if you compare this to the current cost of one IVF cycle, which is a stimulated cycle, is to the tune of around 1.2 to 1.5. Now, ये लेने में उसका almost 60 to 75% of the NNI or the income per year would go. So they are not left with many options. Either they don't, जो प्रीवियस पैनल में बताया गया था कि वो मंदिर की घंटी बजाते हैं, जंतर मंतर के पास जाते हैं. सो दोज आर द काइंड ऑफ सॉल्यूशन दे फाइंड solace in. So that is why we need to think about this, and especially when it comes to the rural area or tier 4 cities or low income groups, that is where we need to focus upon. Next slide please. Cultural social stigma barriers, I think most of the panelists have discussed about it. Next slide please. There is a huge awareness gap, and I would come to the solutions to this in my later slide. But then still it is I mean, even in metro cities and tier 1 cities, if you ask even the medical professional, apart from gynecologists भी ऐसे है कि most of the people, they don't know what is happening inside the IVF lab. And that is where exactly the concern is. Even in metro cities, I would say the awareness is moderate. It is not completely, I mean, they are not fully aware that what happens. Most of the people, they think that IVF किया है तो दूसरे का बच्चा है. And that is where the problem is. Next slide. Now, good that Indian government has come out with a very elaborate, and it is still evolving, the ART Act. Is it an equity enabler or barrier? Now, positives are good. I mean, there are structured way of how the IVF center, level 1, level 2, all these things should be there. And there are challenges which we are facing because we have tasted the dust of the tier 3, tier 4 cities roads. I'll tell you, health being a concurrent subject in the list, which is there in the central government also and in the state government also. ART Act is implemented by state government at a altogether different level, because we have worked in 5 major states in tier 4 cities. The appropriate authority at those state level are not at all aware of what needs to be done. So there is no checklist as such given to them. We are in fact proposing the central government that let us have a mass scale webinars to address the issues which are happening, which are there at tier 4 cities at the level of appropriate authority. उनको मालूम ही नहीं है. बहुत सारे cities में, even in Pune where I come from, the appropriate authorities are PCPNDT authorities, and PCPNDT authority जब inspection के लिए आता है तो उसको बताना पड़ता है कि सर बताओ क्या देखना है इसमें. So there is no checklist even given by, and there has to be uniform system. Kerala में there is a insistence upon getting a embryologist who is having 3 years after doing MSc clinical embryology, who is having experience in a recognized IVF center for 3 years. Now tell me, the act is implemented in 2022, where you will get such embryologists. तो 3 साल होते ही नहीं है. There will be very rare instances wherein people will have. So they were hell-bent upon to get one embryologist who is PhD holder having one experience, and that too they are insisting that PhD full-time करना चाहिए. So these are the things which needs to be addressed. Next slide please. And also I will briefly tell you that in the act, donor gametes का pricing बढ़ने के वजह से there are lot of issues happening at multiple levels. So eventually that burden, financial burden, is passed upon to the patient who are in need. So I think that is also one area wherein the concerned authority need to have a look at it. When it comes to the insurance and IVF, what is missing? I think these are the things which needs to be seen correctly. We are fortunate enough to partner with my good friend Mr. Vikas Anand, his company Safety. They are launching India's first and most affordable insurance for IVF treatment. The policy will be enforced very soon. I think today he is going to elaborately talk upon that. So it is going to be on both the sides. जिनको infertility की ज़रूरत नहीं है वो भी करने वाले हैं, and जिसको infertility बताया गया है उनके लिए भी उन्होंने पॉलिसी निकाला है. So once that is covered, then it makes lot of sense कि equity or accessibility will be covered at most of the places, and this is going to be kind of national level. So next slide please. And I thank Vikas for taking us as a knowledge partner in designing that policy. Now ongoing mitigation, let us have a look at ongoing mitigation. Next slide please. Role of gynecologist, ये बहुत सारी जगह हो रहा है, and that is why I am covering this. Okay, so there are gynecologists who are remotely trained or advised, and then the procedures are done by the qualified ART consultants. So that is happening. Also, I would say that there is a collaborative efforts which is going on कि 10 gynecologists एक साथ आकर they are creating a facility which can be kind of a open culture IVF center, which can be used under a highly trained IVF consultant. Next slide. Cost-effective IVF model is also happening at multiple places like mini IVF. Batch IVF is one very good way to mitigate the high costing in IVF treatment. There are adapted protocols which are again done at tier 3, tier 4 cities by expert ART consultants. Pricing structured, again, I would say that, as you move on to the tier 3, tier 4 cities, the pricing structure needs to be mitigated as per the affordability of the population in that area. And of course, what I was talking about is an open culture IVF center. One good facility like Cloud9 or a Motherhood or a LaFem, like facility which can be utilized by many gynecologists, but then that has to be monitored, and the gynecologist needs to be trained by qualified ART consultant and a team of a good embryologist. Next slide, please. And this is also being used quite rampantly. The tele IVF consultation, the AI power tools, and of course this is just a beginning of AI era. But then still there are a lot of efforts which are going on to develop those systems wherein those will be used quite rampantly, and this will reach to the unreached population which is staying in even metros and even tier 3, tier 4 cities. Next slide, please. Now, this is what we see as a vision. Next slide. Government partnerships and public-private models. Fortunately, in Maharashtra and some of the other states, they are coming up with an IVF center at medical colleges. But again, the tender निकलता है, टेंडर भरा जाता है, IVF सेंटर खड़ा हो जाता है, बट उसको मोटिवेट करने के लिए, रन करने के लिए कोई नहीं रहता है. So this is the irony of it. So I would say that one of the panelists, I think Dr. Keshav said that those facilities can be outsourced to the established IVF players, which can run it efficiently, so that it will be fruitful PPP model. We can always deploy on wheels infertility screening programs at rural places, wherein educate them, screen them. हम लोग बार बार करेंगे तो ही उनके दिमाग में बत्ती ही जलेगा. Unless we do it, I mean, 3 महीने में एक बार करने से होता नहीं है. I think we need to be repetitive in our efforts in terms of screening them and educating them simultaneously. We can also focus upon various NGOs, ASHA workers, even the PSC level health workers to educate them. I think मुझे लगता है, instead of talking only about educating the patients per se, let us think about B2B conversation or education also, so that we can educate the business to business or doctor to doctor communication and awareness, make them aware. Even the GPs are not aware that what is happening. Leave apart the gynecologist in the rural areas, but then we need to address this by mass educating people so that they start talking about infertility issues openly. Next slide, please. We can always think about cross subsidy models in IVF, wherein there are many people who are having a chain of IVF center, wherein their metro city IVF center is doing fantastically well. The price points are also high, but can they deviate some of the profit and subsidize IVF cycles in tier 2, tier 3 cities, which is a great possibility, which can be a great enabler to access to the IVF centers. Of course, there are hybrid delivery models, and then CSR outreach funds. There are many companies which will be interested in doing so. Next slide, please. Policy recommendation for equity would be subsidize the IVF package. Now there are 2-3 thought processes I have. Probably you will see in the next slides how we can subsidize it. Like they have done it in stent, medical gadgets, equipments. Then we can have training program grants from government, which will train larger pool of population, medicos and embryologists at mass scales. Because whatever is said and done, we at least need double the number of IVF centers what we have currently. And for that, the current system is not sufficing enough to cater to that. Building India's inclusive fertility ecosystem, I think most of the panelists, they have discussed and covered all these things. Let us move on to next. Next slide, please. I think this is a very interesting slide, which will show what should be the call to action for stakeholders. Now, what I would tell you is government and policymaker are one of the stakeholders. then gynecologist IVF experts and digital health innovators can contribute in decentralizing the IVF center. Pharma and medtech companies can definitely have a cost-effective tied pricing, wherein media disposable consumables and gonadotropins can be, made available through something called as Jana Aushadhi Yojana. So if a government intervenes and then ask them to reduce the pricing or give them some incentives in which because the major factor in pricing is gonadotropins, media disposable consumable. These are the direct costing. And of course, the manpower cost and the other costs are intangible. So those actions needs to be very collaborative in terms of investors, social entrepreneurs, pharma sector, gynecologist IVF centers, government and policymakers. Next slide, please. The future vision for fertility for all everywhere. I think this is where Oospheere thinks about reaching the unreached, even the unreached in metros and unreached in tier 3, tier 4 cities. How we can do that? To empower the gynecologist in that area and create a facility backed by a trained manpower, ART consultants and embryologists. That facility can be supervised and the procedures can be done there by the experts. But then if you create that facility in the proximity, obviously that will always enable more people to go to the IVF center and take the facility, take the advantage of the facility. And we can always do lot of patient education programs in vernacular. Still IVF के बारे में बहुत कम vernacular languages में, especially when it comes to the South Indian part, vernacular language IVF education is not happening. And whatever is happening is limited to the only people who are using digital platforms like, social media वहाँ पे हो रहा है. So there is no mass scale outreach program to educate the end user of the facility. Next slide, please. Now we have, because we are working in all these tier 3, tier 4 cities or rural India, we have come out with very good sample studies for you. Bid, Satara, Sangli are three very small tier 4, tier 3 cities in Maharashtra. What we have done is we have created a facility which is invested by 1 or 2 gynecologists, and we have developed a pool of almost 20 practicing gynecologists around the vicinity of a radius of around 40-50 kilometers. And those gynecologists are also part of this, not financially, but then they are trained right from case taking se lekar stimulation kaisa dena hai, how to monitor it, and then they are pooling the patient to that. I'll tell you one example wherein we started this in Bid. This gynecologist came to us and he asked कि मुझे चालू करना है, and then how would it work? So we helped them in doing this. He is joined by 20 more gynecologists as associate partner. Initially, when we analyzed his practice, we said that he will be able to generate 6-7 cycles in a month. Now he's sitting on 45 cycles in a month right from day one. And this is happening in a very, very remote place, which is a Adivasi place. So that can be, if that can be achieved in such place, the similar model can be scaled up in various places. Now you would see the key performance KPIs. Time to break even, 6 to 8 months. Patient volume, 240 to 300 cycles a year. Outcome parity, comparable to success rates which are there in metro and tier 1 cities. Now this center is doing everything. Whatever popular terms are there, because I am not a ART specialist, but that they are doing blastocyst transfer, they are using assisted laser hatching machine, they are using whatever embryo glue or whatever, the embryologist would tell me the correct definition. But then the results are beta SCG positive, success rate is around 70-75%, which is unseen, unheard of in that area. So they are very happy. More number of people are getting educated as well as they are taking the benefit of this treatment. So this is what we do. Next slide. This is about us. I'm joined by our director, Dr. Dilip Walke. I am there for almost 25 years of healthcare management experience. Mayura is there, and Advocate Amit Karkhanis is there. Along with this, we have 50 associate working with us. We have 60 odd embryologists and ART consultants on board, and we have full-time biomedical engineers to look after the machinery part. So all in all, right from feasibility to running the IVF center, we help people. We don't give our brand to them. So I can proudly tell that I have chain of IVFs, 30 centers of in a chain, but without my name. So I'm enabling gynecologists, helping them out with a successful business model. Next slide, please. Now, these are some of the actionable ideas. I leave it to you. You can think over it. We can discuss it. Anybody wants my presentation, they can meet me. I am ready to share it with you. Yeah, you can, next slide. Yeah. Can we have IVF screening on wheels in rural areas? Can we have public-private fertility hubs which can cater to the masses? Can we include IVF e-Sanjeevani? Can ESAR and IFS can come together and create a pool of ART consultants which can be consulted anytime by any gynecologist? Can we do that? Or can we have pool of embryologists who can help training the people at grassroots level? Can we come out with Ayushman Bharat inclusion, not with 60,000 of course, because it is 60,000 in IVF treatment in Ayushman Bharat. Can we have IVF innovation? Now we are talking about made in Bharat, made in India. Can we have that IVF innovation challenge every year which is happening in medtech companies also? Can we have IVF Jana Aushadhi? Can we include fertility curriculum in 10th, 12th standard in schools and colleges so that the awareness, because 70%, 74% literacy rate is there now in India. I think we should include this. जितना भी टाबू है उतना निकल जाएगा. And can we have IVF startup incubator in medical colleges? So those who are doing PG in gynecology, they should be taught. They should be also explained the business aspect of this industry, and so that we can enable entire Indian population to have equity and access to all these centers. Next. So India's IVF landscape is growing. Let's ensure it grows fairly. Thank you very much for joining. I am Dr. Madhur signing off. Thank you.
Thank you, Dr. Madhur, for that informative keynote. I now request Dr. Amrita, Public Health Policy Expert at IHW, to felicitate our speaker. Can we have a huge round of applause for our speaker? Thank you so much, everybody.